Welcome to the deep dive. Today, we are getting into something absolutely crucial. The synthesis of classic human anatomy with, well, the reality of modern diagnostic imaging.
Exactly. We're drawing a lot from Anatomy for Diagnostic Imaging, the third edition, to create what we hope is a bit of a shortcut for you.
Right, because for anyone in medicine looking at a CT, an MRI, and an ultrasound, just memorizing names from a textbook isn't going to cut it.
It really isn't. The goal today is to pull out those high-yield, clinically relevant facts. We're talking about the key measurements, the common variants, the things that turn a subtle detail on a scan into a real clinical insight.
It's the why behind the image. So let's just jump in. Segment 1, the cranial vault and face. Let's define some of those key bony landmarks.
Okay, let's start on the side of the skull vault. There are a couple of intersections that are critical topographical markers. First up is the pelcarian.
Pelterian, that's the meeting point of four bones, right? The really thin part of the temple.
That's the one. Frontal, sphenoidal, parietal, and temporal bones all come together there. And its clinical importance is, well, it's huge because it directly maps over the anterior branch of the middle meningeal artery.
Which is why the blow to the side of the head there is so incredibly dangerous. That artery runs right underneath. Classic spot for an epidural hematoma.
Precisely. It's a textbook anatomical weak spot. And then, but more posteriorly, you have the asterion.
Okay, what's that one?
That's where the squamosal suture meets the lambdoid suture. Both of these landmarks are essential for guiding surgeons.
All right, let's move inside to the center of the cranial base. The pituitary fossa complex. It's so compact, so delicate. What are the key markers we need to see on a scan?
Well, we're really talking about the boundaries of the sella turcica. So anteriorly, you have this prominence called the tuberculum sellae.
Okay.
And just in front of that is the sulcus chiasmaticus. It's a critical groove because that's where the optic chiasm lies.
And posteriorly?
Posteriorly, you've got this tall plate of bone, the dorsum sellae, which then kind of flows down into the clivus.
The clinical urgency here always seems to come back to the floor of the sella, doesn't it?
It really does. The floor itself is a very thin layer of bone called the lamina dura. And that is the structure that's so vulnerable to erosion.
From what, like a tumor or pressure?
Either one. An expanding pituitary adenoma can push up and just erode it away, or even chronic high intracranial pressure. Seeing changes in that lamina dura is a massive diagnostic clue.
And that immediately links to surgery. I mean, if a tumor is already eating into the sphenoid sinus, a surgeon absolutely needs to know that.
Of course. And that's where sinus development comes in. Because the degree of pneumatization, the air filling of the sinuses, is so variable.
Especially in kids.
Exactly. The maxillary sinuses are the first to show up. You can see them on a scan just weeks after birth. But the frontal sinuses, they don't appear until around age 2.
And they don't reach full adult size until the teens, right?
Yeah, around age 14. But the sphenoid sinus, the one that's key for that surgical approach, that starts to pneumatize around age 3.
It's a great reminder that the anatomy we're looking at is not static.
Okay, before we leave the head, a couple of quick imaging pearls for the orbit.
Yes, so on an orbital radiograph, you'll often see this sharp, almost straight line. It's called the innominate line.
But it's not a real structure, is it?
Not at all. It's an artifact.
Huh.
It's just the X-ray beam hitting the curve of the greater wing of the sphenoid at a tangent. It's really just a marker of a good projection.
And what about the optic foramen? What are the absolute must-know measurements there?
Okay, this is one of those details that really matters. The normal diameter has to be less than 7 millimeters.
Less than 7.
And, maybe even more critically, the difference between the left and right side should not be more than 1 millimeter. A tiny discrepancy can be the first sign of a big problem.
Let's move down. Segment 2. The vertebral column and its vasculature. How do you instantly spot a cervical vertebra? There's one defining feature. The foramen transversarium. It's a hole in the transverse process.
And that's the tunnel for the vertebral artery.
Right, for the vertebral artery, it's veins and sympathetic nerves as they head up to the brain.
But there's an exception, isn't there, at C7?
There is. At C7, that foramen is often smaller. Sometimes it's not even there. And if it is, it usually just has the veins, not the artery itself. It's a key detail.
Okay, let's talk joints. This is so important for things like arthritis. What about the joints of Luschka?
Ah, the neurocentral joints. You find them from C3 to C7. The key thing to remember about them is what they are not.
They're not true synovial joints.
They are not. They are secondary joints that form from degenerative changes in the disc. People mislabel them all the time.
So you contrast those with the true synovial joints. the facets, the atlanto-occipital joints, the SI joints, and that distinction becomes vital when you're looking for systemic disease.
Absolutely. Take rheumatoid arthritis. RA loves true synovial joints. So in the C-spine, you'll see it attack the joints around C1 and C2.
Which can lead to erosion of the dens.
Exactly. If you see the dens of C2 being eroded, you immediately know why. It's because the joints surrounding it are synovial, and that's the target for the disease. It just clicks.
That connection is just pure gold. Now, the spinal cord's lifeline. First, where does the adult cord, the conus medullaris, actually end?
Usually at the lower border of L1, or maybe the upper border of L2. Anything below that is the cauda equina. But the blood supply is where the real drama is.
It's not just the main spinal arteries, is it?
No, the cord gets reinforcements. There are about 4 to 9 of these little radiculomedullary arteries that feed into it, but one of them is, well, far more important than all the others combined.
You're talking about the artery of Adam-Kivitz.
The one and only.
Yeah.
The arteria radicularis magna. If you compromise this artery, it is catastrophic for the cord. And what's fascinating is its origin is very specific.
So where does it come from? Why is it so critical to find on a scan?
It almost always comes off in the lower thoracic region, somewhere between T8 and T12. And in about 2/3 of people, it's on the left side.
So if you're doing any kind of aortic surgery in that T8 to T12 zone?
You have to find it and preserve it. It supplies the lower 2/3 of the anterior spinal cord. The stakes could not be higher.
Okay, let's move into the chest. Segment 3, the thoracic cavity. Let's talk about the heart's orientation, because it's not sitting straight up and down.
Not at all. The heart has this oblique lie and a slight clockwise rotation. What this means on a scan is that the right atrium and ventricles sit a bit higher and more anterior than the left ones.
So it changes how you see everything.
It changes everything. The septa, for example, they lie in a left anterior oblique plane, but the mitral and tricuspid valves are oriented in a right anterior oblique plane. You have to mentally adjust for that rotation.
And when we look at the heart muscle itself, coronary artery dominance is a term we hear all the time. How is that actually defined?
Dominance is all about which artery supplies the posterior descending artery, the PDA, and the posterolateral artery, the PLA. If the right coronary artery feeds both, you've got a right dominant system.
And if the left circumflex does, it's left dominant.
Simple as that. But that simple fact has a huge implication for one of the papillary muscles.
This is a great clinical pearl.
It really is. The posteromedial papillary muscle usually gets its blood supply from only one source, the PDA. That's it.
Whereas the other one, the anterolateral, has a dual supply.
A dual supply from the LAD and the left circumflex. So think about what happens if a patient has a heart attack that takes out the PDA.
The posteromedial muscle is toast. It has no backup supply.
It's toast. And that means you are far more likely to see severe mitral regurgitation. The lack of collateral flow makes it incredibly vulnerable to ischemia. It's a direct anatomical setup for a clinical disaster.
Let's shift to the aorta and trauma. The big weak spot is the aortic isthmus.
Yes, the isthmus. It's that short segment where the arch becomes the descending aorta.
Yeah.
The problem is it's fixed in place by ligaments.
So in a car crash, a sudden stop?
The rest of the aorta moves, but the isthmus doesn't. You get these immense shearing forces, which is why it's the #1 spot for an aortic tear or transection in blunt trauma.
All right, moving into the abdomen for segment 4, let's start with a really cool anatomical detail of the stomach. The Magenstrasse.
Magenstrasse. Yeah, it literally means stomach street. It's these longitudinal folds along the lesser curve. And they act like a channel.
A channel for what?
For fluids. It allows liquids to bypass the main body of the stomach and shoot straight through to the duodenum.
And that shortcut actually has a very practical, measurable application, doesn't it? Particularly in kids with the pyloric stenosis.
It does. On ultrasound, we have very specific criteria. You measure the pyloric muscle wall thickness. If it's more than 3 millimeters, that's abnormal.
And the length.
And if the muscle length is more than 14 millimeters, that's also abnormal. Those are the hard numbers you use for diagnosis.
Okay, the liver. We all know the surgical segments based on the chordal triads, but the real challenge for surgeons is the incredible variability in the hepatic arteries.
The variations are practically the rule, not the exception. You see a replaced left hepatic artery coming off the left gastric artery in up to 12% of people. A replaced right hepatic artery from the SMA happens in 10%. You have to map these pre-ops.
Or you could have a disaster on the table.
A total disaster. And speaking of anomalies, let's talk about the caudate lobe, segment 1. It's fascinating because it's often totally spared in diseases like cirrhosis or Budd-Chiari. Why is that?
It has its own private drainage system, doesn't it?
That's the perfect way to put it. The other segments all drain into the main hepatic veins, but the caudate lobe has its own small veins that drain directly into the IVC. So
Right.
when the main outflow is blocked, the caudate is fine. It's insulated from the chaos.
And for looking at the biliary system now, what's the go-to?
Oh, it's definitely MRCP, MR telangiography. It's non-invasive. It uses T2-weighted imaging to light up the fluid in the ducts. It has almost completely replaced ERCP as the first-line investigation.
Okay, let's wrap up with our final segment, musculoskeletal, starting with the shoulder. Talk to me about capsular insertion patterns.
Right, on the glenoid neck. There are three main types. Type 1 inserts right behind the labrum. Type 2 is about a centimeter behind. But type 3 is the one we worry about
Why is that?
because it inserts more than 2 centimeters behind the labrum. And that loose attachment actually predisposes that person to a cell AP tear, a superior labral anterior to posterior tear after a major traction injury.
Let's go down to the elbow, the classic elbow effusion sign. The fat pads.
This is just beautiful, simple physics on a
Thank you.
radiograph.
Yeah.
You can normally see the anterior fat pad because the coronoid fossa it sits in is shallow.
But not the posterior one.
Never. The posterior fat pad is buried deep in the olecranon fossa. So the only way you can see it is if something pushes it up and out of that fossa.
And that something is fluid, an effusion.
Exactly. If you see the posterior fat pad, there's fluid in the joint. Full stop. It almost always means there's a fracture somewhere.
So the invisible pad is the one that tells you everything. Okay, knee menisci. On an MRI, what's the key sizing difference we should look for?
In the sagittal plane, for the medial meniscus, the posterior horn should be about twice the size of the anterior horn. For the lateral meniscus, though, the horns are about equal in size.
And how do we grade a tear?
We use the standard grading system. Grade 1 and 2 are internal signal changes. But a grade 3 is what matters surgically. That's when the signal abnormality definitively extends to a surface of the meniscus. That's a tear.
Finally, the ankle. The classic inversion injury. There's a very predictable sequence of what tears first.
A very predictable sequence. We're talking about the lateral ligaments. The first one to go, always, is the anterior talofibular ligament, the ATFL.
It's the weakest.
It's the weakest. If the force continues, the next is the calcaneofibular ligament, or CFL. The PTFL at the back rarely ever tears.
So there's a rule here, right?
There's an absolute rule.
Yeah.
If you see on an MRI that the CFL is ruptured, with 100% certainty that the ATFL is also ruptured, it has to be.
That's a great summary. This has been a fantastic tour of how that traditional anatomical roadmap really explains what we see on modern scans.
Exactly. It's all about understanding why things look the way they do. And what's really stood out is how much anatomical variation drives clinical decisions.
You mean things like the accessory hepatic arteries or variations in the circle of Willis?
Yes. Recognizing those common variants changes the game. Interpretation goes from just spotting pathology to actually understanding a patient's physiological risk and, building a safe surgical plan just for them.
That is a powerful thought to leave everyone with, that the normal we learn in textbooks is often just one of many possibilities. Okay, for everyone listening, let's lock this in with one final exercise. Describe the primary function and the anatomical course of the artery of Adam-Kubitsch. Why is its location, typically between T8 and T12 and on the left, so critical? And what is the major risk if it's compromised? Take a moment and really trace that vessel in your mind.